Welcome everyone to today's program. I am Robert Kurtz, editor of Becker's Hospital Review and moderator for today's program. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have. We'll follow up on questions they do not have the opportunity to address. You'll receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of today's program. You can submit your feedback or any additional questions at that time, but please note that this email will not include the presentation. It is now my pleasure to introduce today's presenters. First, we have Dr. Robert Farrar. Dr. Farrar is the Vice President of Medical Affairs for Somni Anesthesia. With 25 years of clinical anesthesia experience, Dr. Farrar has served in a variety of roles, most recently as Director of Cardiothoracic Anesthesiology and Vice Chairman of the Department of Anesthesiology at Lower Bucks Hospital in Bristol, Pennsylvania, and as Chairman of the Department of Anesthesiology at Easton Hospital in Easton, Pennsylvania. Dr. Farrar received his medical degree from the Catholic University of the Sacred Heart and his law degree from the University of Detroit Mercy. He is board certified in anesthesiology, critical care medicine, and transesophageal echocardiography, and received an additional board certification in medical quality. Next, we have Brent Sommer. Brent is a senior nurse anesthetist at Desert Regional Medical Center in Palm Springs, California, where he is part of an anesthesia care team that performs 6,000 cases annually. In addition to the clinical practice of anesthesia, Brent is also a clinical and didactic instructor at the Kaiser Permanente School of Anesthesia in Pasadena, California. He is a graduate of Ohio University, the University of Pittsburgh, and the University of San Francisco, and received a certificate in executive management from the Kellogg School of Business at Northwestern University. He completed his nurse anesthesia residency at the University of Pittsburgh Medical Center. Brent is also a past president of the California Association of Nurse Anesthetists. Finally, we have Frank Schramm. Dr. Schramm is the Chief of Anesthesia at Providence Regional Medical Center in Everett, Washington. Board-certified anesthesiologist for almost 30 years, Dr. Schramm oversees a team of 35 MDs and CRNAs at one of the top hospitals in Washington State. Dr. Schramm obtained his medical degree from the University of Miami and completed his residency in anesthesiology at the University of Washington. Prior to joining Providence Regional Medical Center, Dr. Schramm was a managing partner of an anesthesiology private practice in Las Vegas. I would now like to turn the floor over to Dr. Farrar to begin today's presentation. Dr. Farrar?
Thank you, Rob. First slide, please. When I begin these discussions, what I like to do is first start out with a definition. And first of all, let's ask ourselves, what is anesthesiology? And this comes right from the ASA, American Society of Anesthesiologists website. And I'm just going to read it for you. That anesthesiology is the practice of medicine that includes, but is not limited to, the pre-op preparation and evaluation of the patient, anesthetic planning and administration, and intra-op and post-op care, and management of systems and personnel that support these activities. Next slide, please. When we look what this is all about, when we look at the scope of what's going on, that approximately 40 million anesthetics are administered each year in the United States, and anesthesia is administered in a number of different locations. The operating room, obstetrics, cardiac cath lab, endoscopy suites, a number of different places, dermatology, urology offices. In short, any time you need to have an individual made insensate to pain, anesthesia services are called into play. Next slide, please. So with such an important endeavor going on, all these millions of anesthetics being administered, how do we actually deliver care? How is anesthesia care delivered? Well, there's two main components, two main groups of individuals that deal with administration of anesthesia. First are physicians, which consist of anesthesiologists and resident anesthesia physicians. They're physicians in training to become anesthesiologists. And a non-physician group, which includes certified registered nurse anesthetists, CRNAs, and anesthesia assistants. Now, for the purposes of this discussion, we're going to limit our discussion to including anesthesiologists and CRNAs. Next slide, please. We look at, who are anesthesiologists? Who are these people that are physicians that are administering anesthesia? Well, an anesthesiologist is a licensed physician who has successfully completed an accredited training program in anesthesiology. There are two components to the preparation to become an anesthesiologist. First, there are both the undergraduate and the graduate medical degree, leading to a degree in medicine or osteopathy. Then there's the formal training component of actual hands-on anesthesia clinical training. This consists of a 4-year residency. The first year is generally an internship in either medicine, surgery, or sometimes family practice, and then 3 years of clinical anesthesiology hands-on training. And during the course of those 3 years of clinical anesthesiology training, the anesthesiology resident is exposed to a variety of different disciplines, such as cardiac anesthesiology, obstetrical, neurosurgical anesthesia, pain management, intensive care. In fact, there's 4 months, a minimum of 4 months is devoted exclusively to critical care, and 3 months is devoted exclusively to pain medicine, as required by the American Board of Anesthesiology. Now, many physicians will then go on to a fellowship or subspecialty training. I did subspecialty training in cardiothoracic anesthesia and critical care medicine, but there are a variety of different disciplines such as pediatrics, pain, neurosurgical, obstetrical, a variety of different subdisciplines of anesthesia where people can get extra training. Now, if you note that the total amount of time here in preparation is about 12 years that goes in the training of the anesthesiologist. And this stands in slight contrast to the CRNA, an advanced practice nurse, who we'll see on the next slide, please. Next slide, Ron? There we go. Thank you. Who are certified registered nurse anesthetists? A CRNA are advanced practice nurses who have extensive training in the administration of anesthetics. They have satisfactorily completed a nurse anesthesia training program after having received a Bachelor of Science in Nursing. Their formal training during the course of their nurse anesthesia program consists of 2 years of clinical anesthesia training, again, at which they're exposed to a variety of different disciplines of anesthesia care. And this is after their internship year, so to speak, where they get at least 1 year minimum as a registered nurse in an acute care setting. Their program is very rigorous, albeit not quite as in-depth as that of the anesthesiologist, but nonetheless, this produces individuals, competent, high-quality anesthesia providers. Next slide. When we look now at how anesthesia care is delivered, when the rubber meets the road, what are the different models that we're looking at? Well, first and traditionally, anesthesia care has been provided by physicians in the MD-only model. Now, what this means is there is one doctor to one patient administering anesthesia. Now, I'm going to go to the other end of the spectrum right now and just mention that when the CRNA-only model is a relatively recent innovation and is only actually limited to a few states that allow independent CRNA practice model. Also, many of the CRNA-only models, they're frequently seen in rural hospital settings where the caseload is insufficient and cost ineffective to attract an anesthesiologist. At Somnia, we've embraced the anesthesia care team as our predominant practice model, and for the reasons that I'll be describing shortly. Next slide, please. The anesthesia care team is the model of anesthesia practice in which the anesthesiologist directs and delegates the monitoring, administration of anesthesia care, and other types of tasks to non-physicians. Now, what this means in practical terms is that the anesthesiologist is, for all intents and purposes, the captain of the ship by managing and directing multiple aspects of the administration of anesthetics and perioperative care for our patients. Next slide, please. Now, when we talk about implementation, or again, rubber meets the road of the anesthesia care team, the anesthesiologist is the one that, again, stands as captain of the ship and directs and leads the team. The responsibilities are legion. They involve personnel management, preoperative evaluation, pre-anesthetic evaluation and optimization, consulting with the surgical team, coming up and prescribing an anesthetic plan in concert with the needs of the patient in the prescribed surgery, inserting lines or performing blocks as may be necessary for the patient care and comfort, and then actually supervising the administration of the anesthetic. We're also responsible for post-anesthesia care and anesthesia consultation as may become necessary for other endeavors during the course of our care of the patient. Now, because anesthesia is involved in many areas of patient care, they have to collaborate with many stakeholders throughout the facility. And sometimes anesthesia is just looked at as another clinical expense. In reality, what we do is a dynamic, multidisciplinary process that touches multiple aspects of patient care. Next slide, please. Again, within this context, the CRNA is the actual hands-on, in the context of the anesthesia care team, the CRNA is actually the one that is in the room, responsible for the one-on-one administration of anesthesia care under the supervision of the MD, the anesthesiologist. And the responsibilities, very important responsibilities, hands-on involvement of the CRNA include collaborating with the anesthesiologist and formulating and executing an anesthetic plan. They, again, as I mentioned, they provide one-on-one delivery of anesthesia care. They assure safe transport to and from anesthetizing locations. And they truly assist in multiple aspects, not just post-op and pre-op, but multiple aspects of care of the patient. Next slide, please. Now, within this context, the anesthesia care team model, there has been absolutely no data. Let me step back for a second. Frequently, the question comes up, how safe is the anesthesia care team? And this is the answer. There is no study conclusively to demonstrate that MD-only anesthesia model is superior quality and safety to the anesthesia care team model. And again, this is the model that Somni has embraced. Next slide, please. Now, why should we even consider the anesthesia care team model? Why even bother? Well, and why are we discussing this right now instead of MD-only anesthesia? And why has Somni embraced this model of anesthesia care? Well, first of all, there is an extremely high demand for anesthesiologists. There is a low supply of practitioners, so we have high demand, low supply, and costs are going through the ceiling. Next slide, please. High demand. There has been an explosive increase in outpatient services, including office-based procedures. And as more invasive procedures are being done as outpatient procedures and the demand for anesthesia to allow those invasive procedures is increasing as well, we have the demand for more anesthesia care. The United States population is getting older. Patients are sicker. The demand for skilled, high-quality anesthesia providers, as opposed to physicians frequently providing their own sedation for some procedures, has increased. And as I mentioned earlier, any time you need to make an individual insensate to pain, anesthesia services are called into play. Next slide, please. So in the face of high demand, we now have low supply. And this is a graph that comes from the RAND Corporation. And as you can see, that with one exception, that across the board, throughout any area and region of the country, we have a low supply, a deficit, so to speak, of anesthesia care providers, whether MDs or CRNAs. We have a decreased supply. So obviously, when you have an increased demand in the face of decreased supply, this is obviously a serious problem. Next slide, please. And if you want to really rub salt in the wounds, we have skyrocketing costs that are making a lot of different aspects and models of delivery of care prohibitive. If you consider cost of the physician-only model in the face of decreasing revenue and reimbursement, what this translates into for many of our facilities is an increase in the anesthesia subsidy. So let me translate this into some kind of simple numbers. As an example of costs incurred, consider the following. If we have 4 anesthetizing locations just during quote-unquote business hours, like no call, no cardiac, no OB, just 9 to 5 anesthesia, surgery center type stuff. And if we have 4 MDs covering those 4 anesthetizing locations at an average salary of $350,000, the cost is $1.4 million. Now, looking at that a slightly different way, if we have 1 MD covering 4 CRNAs, the cost will be 1 times $350,000 plus 4 times an average salary of $175,000, costing $1,050,000. So without taking any other variables into consideration, the savings to the facility is about $350,000. It's quite a bit. Moreover, having an MD who is supervising CRNAs available to direct clinical and other throughput activities can see the patients ahead of time, facilitating and maximizing efficiency of the OR turnover is definitely a value added. And lastly, from a clinical perspective, should there be a critical event in the operating room, a spare set of experienced hands is free to intervene in the care of the patient. Next slide, please. When we look at to the facility alone, not even considering the other different components, if we look at the benefits of the facility alone, this is one method of ensuring high quality and safe anesthesia care. It's cost-effective anesthesia care. It maximizes the efficiencies through use of our personnel. You can increase the capacity, the supply, which Dr. Schramm will be talking about very shortly. It also helps address the shortages. Remember, we mentioned the number of shortages we're facing. And also, this is able to provide high anesthesia care, quality anesthesia care to high acuity patients. All this translates into an added value. Next slide, please. When we look at what the benefits to the provider are, the people that actually deliver the anesthesia care, what we have now is not just one-on-one solo practice, one person dealing with anesthesia, but we have now a shared and collaborative practice. There's reduced fatigue, less burnout. There's a lot of increased opportunities for exchange of ideas and strategies comparing patient care. And I will go so far as to say I believe personally that it is even safer. Next slide, please. So in summary, the anesthesia care team model is a cost-effective, high-quality alternative to MD-only delivery of anesthesia care. Within a context, it bears mentioning that the experience and scope of an anesthesia management company such as Somnia makes a huge difference. Hospital executives rely on partners who have a clear understanding not only of the clinical issues, but also of the numerous regulatory requirements, which we barely mentioned during this part of the discussion, for delivering anesthesia services. An anesthesia management company with an infrastructure of physicians, legal, and operational expertise provides hospitals and other facilities with comprehensive support that they need to succeed. The facility's anesthesia partners should provide measurable metrics for performance that has an effective tracking mechanism, proof of compliance with all internal and external regulatory performance standards, and documented evidence of improvement. So with that being said, I'd like to turn this over to Brent and discuss the next phase of our discussion here in the anesthesia care team model. Thank you. Brent is our Desert Regional Medical Center in Palm Springs, California. And Brent, I'll turn this over to you now.
Thank you, Dr. Farrar. Next slide, please. Next slide. My career as a nurse anesthetist took somewhat of a circuitous route from when I originally started college with the hopes of getting a degree in political science and following the tracks of some of my family colleagues into the law profession. I quickly found that my interest didn't lie there once I was exposed to a hospital and pre-hospital care environment. As an undergraduate student, I found an opportunity to be able to take some free EMT training because I was having trouble finding a job to support my education, which led me to the hospital shortly thereafter, becoming an orderly and eventually a nurse and physician assistant, RN, and eventually to my track that I think I originally was most enamored by, a career in anesthesia as a nurse anesthetist. My experience since becoming a CRNA some 30 years ago has been quite broad. I had a broad-based nursing experience in critical care of CV-ICU, surgical intensive care, and neurosurgery. The clinical training that I was afforded in my nurse anesthesia training program taught me a lot in 2 years. The didactic and clinical components of my training sent me through 8 different hospitals, and I accumulated experience up to about 1,200 cases throughout. The particular experience that I had was in a joint training program at the University of Pittsburgh, where we trained side by side with physician anesthesia residents as well. So my experiences have been multitudinal, leading me to my current position with Desert Regional, where I joined the team just about 1 year ago. Next slide, please. Desert Regional is one of 3 licensed facilities in hospitals in the greater Coachella Valley, located in downtown Palm Springs. It's a 381-bed acute care facility, which is also a level 2 tertiary trauma center, fully accredited, and we do just about 6,000 cases a year in the main OR, which is 8 rooms. We also probably do close to about 200 out of operating room cases that usually involve monitored anesthesia care and conscious sedation, as well as some generals in our outlying areas, including our neuro-orthopedic science facility, interventional radiology, cardiac cath lab, MRI, and CT scan. Next slide, please. Adjacent to our medical center is a outpatient ambulatory surgery center, which houses 5 operating rooms, including a cystoscopy center. And we do just about 2,200 cases a year there as well. Our team staffs both facilities 5 days a week and 24/7 throughout on call. Next slide, please. Prior to the Somnia team acquiring the contract, about a year and a half ago at Desert Regional, there was an independent group of physicians, about 13 physicians and just 1 CRNA, that covered all of the services that we have acquired since assuming the contract. That 1 CRNA and a couple of the physicians did join our Somnia team once we became active. They acquired the exclusive contract for several years, and I believe one of the reasons that Somnia was considered for the contract, that we were able to address a lot of the expanding service demands the facility and the organization were having placed upon them by not only a lot of the outlying procedures that I described earlier, but the increasing demands of not only providing conscious sedation throughout the facilities, but also some of the demands that were coming from compliance and organizational demands to meet state and regulatory efforts and demands. We had a pretty smooth transitioning. I wasn't directly involved immediately when the team took over, but from all reports and what I've seen since I've been here, it's been quite smooth and met with extreme acceptance and support throughout the organization. Next slide, please. We have a care team model, as Dr. Farrar described earlier. We have roughly 10 physicians and 10 CRNAs. We actually have a lot more bodies than that because several of us work part-time. The ratio that we maintain in our routine day-to-day flow in the operating room is a 4-to-1 ratio of 4 CRNAs working with a facilitator or a supervising anesthesiologist. As our rooms expand, we expand the number of facilitators or the physicians that are able to manage and supervise our rooms. As you can imagine, it requires some administrative support. We have a strong team, both locally and nationally, to help us do that. Our cases are orchestrated according to acuity and complexity, and this affords someone, either the facilitator or a co-facilitator, which is frequently a CRNA, to be able to best examine and prepare the patients for their upcoming procedures and techniques. In that way, communicate to the people who are actually be doing the procedure, or give them the availability and free them up to go see the patient and be participatory in their organization of their case. I like this opportunity to be able to have more input into the cases rather than just have one case after another, which can happen in a busy place. Worked in several university hospitals and HMOs in the past, and the supply and demand just is a driving force, which you don't always really get to see your patients ahead of time. So you might not be able to understand the complexities of what they might require during their anesthesia. But in this model, it seems to be better supported, and it's one of the attractors for me. All of us are expected to practice within our full scope of practice, both in terms of licensure and credentialing as well, and that is refreshing. Next slide, please. Our schedules and assignments are predetermined, and the cases are facilitated, as I mentioned, from a day-to-day, and communicated the day before or day prior to the provider, so we'll know what we're doing the next day, have an opportunity to look on the electronic record, or maybe even meet and examine the patient, get to know our patients as well as the surgical team who will be participating in the case. As you can imagine, being a trauma center, many of our cases are experienced repetitively because they're trauma and post-trauma stabilization, mostly orthopedic and neurosurgical cases. So some of these cases are frequently repetitive, and we might be taking care of the same patient several days throughout the month or their stay at the hospital. The cases are orchestrated and accommodated to best meet the demands not only of the surgical services, but the providers with the most greatest amount of expertise and interest and experience in that specialty area. And as you can imagine, communication is critical to having this run as a smooth operation. Next slide, please. I believe that throughout my career I've had a lot of practice choices. I've pretty much done the gamut from university to teaching hospitals, large HMOs, small group, independent practice, and even a small stint for a few years in a rural hospital, West Sonoma County, as one of two independent providers in a very small facility. I look at what makes a successful practice and as well as the best opportunities for a CRNA, and I think what is important to me are the partnerships that can be made and that everyone has a commitment to excellence and are on the same page to speak as where they want to go with their practice as well as the service they can deliver. Next slide, please. So when I'm looking at independent practice versus that where I'm supervised, I have some absolutes that I take into consideration, of course. The top, I believe, being safety, a service that I can be proud to deliver, have the resources and the opportunities to deliver what I consider the safest degree or panel of care to the patients that I serve, as well as the other customers, my clients, being the surgical services and the preoperative services that we service. And of course, satisfaction can't hurt. I like to be satisfied and feel that I've made a difference in the job that I do. Some of the other qualifiers, of course, are that we maintain a solid and strong standard of care. Regardless of licensure or certification, I believe all anesthesia providers are gauging for the highest standard of care that we can possibly deliver. I like a diverse patient population, and I believe that you need enough manpower backed up by not only experience but expertise, and to be able to deliver such a wide variety of care similar to that we can do at Desert Regional. And of course, you need resources to be able to do that. And I feel that we benefit not only from our national support, but our local commitment and team to be able to give the best care we can because we have the resources in which to do that. Next slide, please. I think one of the benefits of the CRNA inclusion, as Dr. Farrar already alluded to, of course, is simple 10A of supply and demand. When you have a group that comes together to develop and orchestrate what we've got here at Desert, you're getting the benefit of a wide span of education, expertise, and quality. That people come from different viewpoints, but also end up all wanting the same outcome, that of safety, be able to have large degrees of productivity, and at the same time have a satisfying practice. Next slide, please. One of the main reasons why I decided to work and partner with Somnia is because, as Dr. Farrar started to address toward the end of his presentation, is that we take a look at the care that we deliver and try to learn and substantiate what we should do or could do to make our care better, qualify the care that we provide, and measure our performance. We do this by basic 4 major areas in which we look at our professional development of not only of our team but of our colleagues. We maintain what we can conceive, develop, and orchestrate into the highest clinical standards possible, based not only on evidence-based facts, but what works best for that institution. We look at ways in which we can improve our performance daily. We have 100% case review of all of our cases to see how we might do something better or to learn what might have worked great and share with our other colleagues. And of course, customer satisfaction, not only from a patient perspective, but that from the perioperative services and of course the organizational leadership with which we've partnered. That's the end of my presentation. I'd like to turn the talk over now to Dr. Frank Schramm from our Northwest.
Hello, my name is Frank Schramm. I'm the Chief of Anesthesia at Providence Regional Medical Center in Everett, Washington. Robert, could I have the next slide, please? Providence Regional Medical Center is, as I mentioned, located in Everett, Washington, about 20 miles north of Seattle. We are a 372-bed acute care hospital, 15 operating rooms, conducting between 12 and 13,000 surgical cases per year and 4,000 deliveries in our labor and delivery suite. We've been ranked in the top 100 hospitals in the United States on several occasions by Thomson Reuters. Currently #1 in Washington for cardiac and critical care, stroke, and general surgery. Next slide, please, Robert. The history of anesthesia at this facility is somewhat involved, as I'm sure it is in many places. Historically, the hospital was staffed by an all-MD anesthesia group, and the hospital was paying a significant, in their opinion, and in the opinion of many others, unsustainable anesthesia subsidy. They wanted expanded anesthesia service in other areas of the hospital other than the operating room and the more conventional areas. They also wanted an anesthesia team that was more involved in the hospital's medical staff infrastructure, including committee membership, quality improvement, and other obligations that have historically been shunned by private practice anesthesia groups. They also wanted a flexible, responsive anesthesia team that could address the changing landscape of hospital-based health care, and wanted to maintain a high-quality standard of care for their patients and surgeons. Next slide, please, Robert. As I mentioned, the prior group was made up of all MDs. There were 24 members, and they were felt to have delivered a high quality of care. However, they provided limited coverage due to their relatively small size. They were unwilling to employ or work with CRNAs as an avenue toward reducing their stipend and increasing service. They were unwilling or unable to participate in medical staff infrastructure to any significant degree, had little or no involvement in the quality improvement realm, and were characterized as being somewhat inflexible and unresponsive to the hospital's changing needs. At the time the RFP was let, they also demanded a much higher subsidy to move forward. Next slide, please, Robert. The care team model we have at PRMC now is made up of MDs and CRNAs. We have currently 18 MDs and 17 CRNAs. There are 21 anesthetizing locations in our facility. We have 2 campuses, which include an ambulatory surgery center with short stay capability, labor and delivery unit with a NICU, and our main operating room where we provide the majority of service to our more complicated patients. Service lines include general surgery, ENT, neuro, ortho, gynecology, and gynecologic oncology, robotic surgery, vascular surgery, thoracic, cardiac surgery, and urology. Next slide, please. And in terms of how our care team works here at PRMCE, we employ a sliding scale supervision model. CRNAs were initially completely supervised in the typical sense of the supervision model. However, after a period of time, it was recognized that our CRNAs would be capable of some independent practice, and therefore we exercised the opt-out provision provided to us by our state legislature. CRNAs typically provide care to patients on the OB ward and at the ambulatory surgery center. And when CRNAs are scheduled at the main campus, they care for higher acuity patients with the anesthesiologist, coordinator, or facilitator acting as a clinical resource and participating to varying degrees in the care of the patient. Next slide, please. We view anesthesia as a quote-unquote team sport. Preoperative evaluation, blocks, line placement are typically carried out by the coordinator or facilitator MD who are not directly involved in patient care in the operating room. Advantage of this model includes the ability of the coordinator or facilitator to assist any clinician, MD or CRNA, with patient care. We feel that patients are better and more safely cared for with more hands on deck. We have a wide-ranging patient case mix, and we find that the best course of action is often determined based on the patient's needs. Some patients are best cared for by an MD, and many of our MDs do cases on a daily basis. Some are best suited for care by both an MD and a CRNA in a supervisory situation, and many of the patients of low acuity are well cared for by a CRNA with limited supervision, basically a collaborative discussion of the patient's care prior to the administration of the anesthetic without the standard intervention of supervision or direction. Next slide, please. The care team model at PRMCE is somewhat unique, and I will tell you that it requires a specific set of skills in order to facilitate its function. As far as recruiting individuals to our facility, we carefully select anesthesia providers, both CRNA and MD, that understand the nuances of our care team model. We understand that each MD and CRNA has skills and weaknesses, and that cases must be assigned appropriately based on those and the needs of the patient. Opportunities for clinical growth for both MDs and CRNAs abound at our facility. Next slide, please. And then we move on to why I believe our care team model works at PRMCE. We do have flexibility in our assignments. We have the ability to deal with patients with vastly differing acuity levels. And there is a broad spectrum of experience across case types, both in past experience by providers and in current experience associated with the care of these patients. We feel that we deliver quality care in a timely, cost-effective fashion. Our current model works and accomplishes our goals and objectives. An important facet of our practice is that of communication. MDs outside of the OR act as coordinator/facilitator, preempting issues, for example, the early recognition of a difficult airway, abnormal lab values, values that are not present on the chart which have to be searched for, the usual things that can result in slowing down the throughput of the operating room. The assignment of cases is made to CRNA or MD by the chief, who builds the schedule every evening for the next day. Coordinator and facilitator discuss individual case issues with the practitioners who will be delivering the care, reach an agreement, and help in the execution of that plan. Next slide, please. We find that patients' needs are greater, especially in this day and age. A larger team providing care for this patient population is very helpful in that the patients are generally older and suffer from multiple comorbidities. Anesthesia delivery is tailored to the needs of the patient and represents a continuum of care from the pre-op area to the PACU and then on to the arena of post-operative pain management. We have developed a culture of collaborative care which recognizes the individual provider's abilities, both strengths and weaknesses, as well as the individual needs of the patient. Next slide, please. And as far as the benefits to the stakeholder associated with the implementation of our model, the hospital was able to replace 24 providers with 35 providers, which significantly expanded coverage in the operating room and out of the operating room. In addition, maintained a very high level of quality care throughout the facility. We were able to reduce our response time on labor and delivery to less than 5 minutes for an OB epidural request, a complaint that had been disputed or had been expressed as being associated with the prior group. We have a robust quality program with national support from SOMNIA. We have active participation in implementing core measures and compliance at our facility. And lastly, but not leastly, the subsidy was eliminated. As far as benefits to the patient stakeholder, all providers are aligned with patient care needs. Our goal is the care of the patient. We have very high overall positive patient satisfaction scores. Our mortality statistics are below the national average for similarly sized facilities, and our current incident rate for all anesthetics delivered is 0.27%. Next slide, please. Benefits to the anesthesiologist I personally embrace and champion the idea of the anesthesiologist as the perioperative physician. This model allows us to best utilize our medical training to facilitate the care of the largest number of patients at the same time. We address the medical needs of the operative patient in order to maximize the chance for a positive, safe outcome. We serve as a ready resource for CRNAs and other perhaps less experienced MDs to provide intellectual and/or clinical assistance. One of the benefits to the CRNA stakeholders is that they have an active understanding of their roles, abilities, and experience, in addition to the fact that their cases are assigned based on their abilities and skills, allowing them a certain degree of independence which they may not or might not otherwise experience. Next slide, please. As far as clinical outcomes are concerned, the topic of the talk today is quality excellence in the operating room. I will say that our current model provides clinical quality that is at least as good as it was prior to the advent of our group at this facility. The mission of our department is and continues to be the high quality of care of patients in every situation that we encounter them. We are very strict in terms of our quality assurance with 100% self-reporting. We review all charts on a daily basis for compliance. We review all charts that have been identified to have clinical indicators associated with critical incidents or adverse events. Based on benchmarking comparisons to other Somnia facilities, the quality of care delivered at our facility is high. Next slide, please. As you can see from this report or this graph, we have a representation of SCIP core measure compliance from 2008 through 2010. We started work at this facility mid-May of 2009, and as you can see, based on the graph, we had a significant improvement in quite a few of the core measures which you see represented here. Next slide, please. Final takeaway is that all stakeholders at our facility are satisfied with the anesthesia care team model. We have significantly expanded services at our facility. We are providing equal or better quality of care than had been provided previously. We are actively participating in value-based purchasing and HCAHPS measures. We provide a flexible, responsive staffing model with access via Somnia to nationwide recruiting, which assures a steady supply of qualified applicants for our growing needs. I'm going to turn this back over now to Robert Kurtz, our moderator.
Thank you, Dr. Schramm, and I want to thank Dr. Farrar and Mr. Sommer as well for a very informative presentation. We will now begin the Q&A portion of the program. To remind attendees, if you have any questions, you can submit them by typing them into your control panel in the space labeled Enter a Question for Staff and click Send. Our presenters will attempt to address as many questions as they can during the time we have for the Q&A, and we will pass along any questions that they do not have the opportunity to address. Let's jump right into the first question, which is directed to Dr. Farrar. Dr. Farrar, what do you see as the biggest challenge toward implementation of the anesthesia care team model?
Thank you, Rob. I think one of the things that is a impediment is that, you know, it's sometimes hard to teach an old dog new tricks. So sometimes people have gotten so used to a certain practice model that introducing a new one creates, especially in the medical field when the stakes are so high, creates a great degree of consternation in particularly surgeons that are now being exposed to a newer practice model. And so I see that as one of the biggest things, is in implementing a new system of medical practice where something may have worked, at least the perception that it may have worked well in the past. And the way that we generally have implemented that is we take a very guarded approach. We let the surgeons opt in or opt out of using CRNAs in the practice, and where we have actually brought that model from an MD-only model to an MD-CRNA mix using the anesthesia care team in a graded, stepwise approach, it has been met with great acclaim, so to speak. One of our most recent hospitals that we have in New Mexico was an MD-only model. We introduced the anesthesia care team, again, in a stepwise fashion, and out of the 60 surgeons that are in that institution, only 2 had any objections at this point. So it's been very well received.
Excellent, thank you. Next question is directed to Mr. Sommer. Brett, how do you feel personally working under the direction of a physician? Does it negatively influence or impact your feeling of autonomy?
Not at all. I feel that I have as much to offer the patient as to my colleagues, and that collectively together is hard to beat. I think that one of the key components to developing our team is to select the right people to join. And we take our recruitment and hiring process very seriously. We take a serious look at people that are well-suited for our facilities. And I really don't ever feel that I have my autonomy challenged. It might help that I have so much experience, and I've given anesthesia for a lot of years. But I never felt that I was not in a collegial situation or supported if I felt that I needed to be. And I'm not shy either. I would ask for help or support or whatever it might be if need be. And that I feel very safe in doing that in this kind of an environment.
Terrific, thank you. Next question I'm going to direct to Dr. Schramm. How does Somnia handle the transition at facilities where they are granted the contract? Can you speak to that?
Yes, I can, actually. Somnia has a full implementation scheme which involves needs assessment of the facility prior to the transition period, and it also has a panel of advisors who have all been through transitions at other facilities readily available to provide assistance and guidance. The transition can be a difficult time. There's no doubt that that is true. However, the fact that Somnia has handled so many of them tends to smooth out a lot of the rough edges, as many of the issues can be anticipated and dealt with before they arise.
Excellent. Thank you. We have time to get through a number of questions before we get to the next one. I just want to draw the attendees' attention to the final slide here. Definitely encourage you to, if we don't address a question that you have or you have follow-up questions, can certainly contact Somnia directly. They provide their contact information here, phone number, email address. Visit their website, and I also encourage you to visit that final link there, www.somniainc.com. /CRNA to read a white paper related to the topic that we are discussing today. Getting back to the questions, next question I'm going to direct to Brent. What legal parameters predicate your ability to practice as a nurse anesthetist?
Sure. I work under my RN license, and that is state by state. So I have a California state license, which actually affords me the opportunity to, for one, manage, administer controlled substances. But the certification is a national certification that comes through the Council on Certification under the auspices of the American Association of Nurse Anesthetists. And the third thing that would predicate my ability to practice would be my credentials and privileges. We are credentialed as members of the medical staff at the hospitals where we work. But the main legal guide would be my RN license.
Thank you. Next question goes back to Dr. Schramm. Can you address the roles of physician anesthesiologists in CRNAs in the care team model from the standpoint of patient safety and care quality?
Yes, I can. Again, I tend to view our relationship with one another as having a common goal, and that is the excellent care of the patient. Anesthesiologists, physicians have typically a breadth of knowledge associated with medical comorbidities and the conditions associated with the patient's other medical concerns, which may or may not influence the choice of anesthetic or the path of the anesthetic care, including issues which might arise emergently intraoperatively. The nurse anesthetist is basically our eyes and ears in the operating room, and we trust them to provide excellent anesthetic care to the patient during the intraoperative procedure. Again, at our facility, we emphasize the role of physician as a perioperative physician and the CRNA as the intraoperative clinician. Typically, the lines tend to blur in the interface over the patient. And that, I think, is where we do some of our best work, in fact, providing a seamless experience of quality care for our patients.
Terrific. Thank you. Next question is going to go to Dr. Farrar. Does Somnia provide consulting services to hospitals that would like to implement such a model internally using their own teams?
Well, We do provide consulting services. We as a company go in and do a complete needs assessment. I mean, obviously we prefer to provide the anesthesia care ourselves. What we generally do when we do go into a facility, whether it's ambulatory care facility or a hospital, is we make a needs assessment, find out what is going well, what is not going well, and it is our fervent hope to try to use the anesthesia care providers that are there if they're actually contributing to a net positive outcome for the practice of medicine. There have been different facilities where people have left. There's been places that we have gone to where people have been asked to leave. And again, the net vector is in a positive direction because the goal is to provide, again, high quality, safe, cost-effective patient care. So I guess in summary, yes, do we provide consulting services? Yes. Do they implement their own internal teams? The answer would be yes, but we would like to have that under the management rubric of Somnia since we have a very robust quality practice model infrastructure.
Excellent, thank you. We have time for a few more questions, so let's continue. Next question is to Dr. Schramm. Since you have two groups who coordinate assignments, is there any sibling rivalry between the groups?
I'm not sure that I don't believe that the person who asked the question understood our model. There are not two groups. We have one group. And the assignments are made by the chief of anesthesia to various providers, CRNA or MD. So there is no internal conflict. There is one group. There are not two groups.
Thank you for the clarification. Next question is going to go to Dr. Farrar. Is the anesthesia care team model effective for both hospitals and ambulatory surgery centers?
Absolutely. It is a great model for both. Again, the concept here is that you have people in the operating room, advanced practice nurses and physicians providing one-on-one anesthesia care, being supervised by a physician. Whether it's an ambulatory care facility or a hospital, it makes absolutely no difference.
Thank you. Next question is going to go to Mr. Summer. Brent, how does the anesthesia care model intersect with surgeons? How and when do they interact?
Well, continuously and daily, actually. When I first started in a site like I'm currently, if the surgeons aren't familiar with nurse anesthetists, the first thing I would do is communicate with them, of course, and introduce myself, let them know that I'll be providing their anesthesia, doesn't need anything special. And I've never really had a problem doing that at all. But usually before, it's the transition that Dr. Farrar was addressing to earlier, when our company transitions into a facility, there's plenty of time before we ever actually take over the department, if you will, where people have an opportunity to meet, both socially and professionally, to be able to discuss how they see things happening and to answer a lot of the questions that might evolve. So the transitions that I've experienced have been very smooth, and I haven't had anything but a positive energy about it or feedback.
Thank you. Next question is going to go to Dr. Schramm. How did the rest of your medical staff accept the addition of the CRNA to the team?
Well, of course, initially, the CRNAs represented something of an unknown to many of the surgeons. I will say, though, that based on our model and its function, the acceptance of the CRNAs has been high. They are members of our medical staff. They are regarded as providers of anesthetic care in the intraoperative setting. There is also a definite understanding of the role that they play in the operating room vis-a-vis their relationship with the anesthesiologists in the department as well. And so overall acceptance has been very good. There have been very few negatives associated with it. And those that were raised initially basically evaporated.
Excellent, thank you. I believe we have time for one last question before we take that final question to conclude today's program. Again, encourage you to contact Somnia directly using the information on this final slide. And if you have any additional questions or feedback, you can certainly reply directly to any of the emails you've received about this program. Since you registered, they'll come to us, and we'll make sure to pass those along to today's presenters. Final question for today goes to Dr. Farrar. Dr. Farrar, can you comment on the pressures your organization faces with regard to hospital administration desires to increase standardization targeted at improving care quality and cost reductions, and importantly, how it affects physician choice over treatment paradigms?
Great. That's a great question, Rob. Thanks so much. First of all, Somnia is at the forefront of standardizing different aspects of medical care. We see this through our policy and procedure manual that uses the American Society of Anesthesiologists practice guidelines, standards, and practice parameters to try to establish, again, high quality, effective, standardized care throughout our system. And when you have standardized care, what you do is you reduce variation. When you reduce variation, you reduce the possibility of risk being introduced into the system. So let me see the second part. We definitely desire to increase standardization throughout. We like to have there be effectively a Somnia way of doing things, which is totally keeping with the standard of care, is up to speed with evidence-based medicine, and in sync with the American Society of Anesthesiologists guidelines, standards, and recommendations and practice parameters. So quality ultimately is cheaper. It's cost-effective. And importantly, how does it affect physician choice over treatment paradigms? We provide a great degree of flexibility with what the ultimate treatment is. We set guidelines and parameters, boundaries along the lines of standardized care, evidence-based care, and within those guidelines or boundaries, so to speak, we allow our physicians a lot of flexibility, physicians and nurse anesthetists, a lot of flexibility for the actual hands-on. I'm not going to try to, from across the other part of the hospital, try to tell someone who's there seeing a patient, looking at the blood pressure, seeing the heart rate, et cetera, what they need to do at any particular moment in time. That's why we train them as well as we do. So in terms of how it affects physician choice over treatment, you have a lot of flexibility, a lot of liberty to do what you need to do for best patient care. But it's going to be within the context of societal standards, practice parameters, guidelines, and evidence-based medicine.
Terrific, Dr. Farrar. Thank you. And again, I want to thank Mr. Sommer and Dr. Schramm for a terrific presentation. Really appreciate your taking as much time as you did to address as many questions as you did. Again, last time I said, encourage you to contact Somnia directly using the information on this final slide. Please reply also to any emails you've received about the program with any feedback and additional questions you have. I want to thank today's presenters. I want to thank the attendees for taking the time to join us. For those of you who had questions we did not get to, we'll pass them along to today's presenters. Again, Dr. Farrar, Dr. Schramm, Mr. Sommer, thank you for a great presentation for the Q&A. The attendees, really appreciate you taking the time to join us today. This concludes today's program. I wish everyone a terrific afternoon. Thank you.